Yes, let's see who's going to present the case. Dr. Nenov is going to present
Dr.
the case.
Nenov will present the case.
Hello everyone. Let me present the case. It's about 70 years old female patient with atrial fibrillation and chest pain during episodes of arrhythmia. The patient is with hypertension, dyslipidemia, and also with diabetes, which is insulin dependent. Here from the ECG you can, we have sinus rhythm with left bundle branch block, and from echo preserved left ventricle function with normal kinetics and valves. Here you can see the film, the right coronary artery which is normal, and one ostial severe stenosis of LAD. This is the case for first case.
So we have Dr. Chilingirov and Dr. Zheleva in the CAD lab. Dr. Zheleva is just proctoring. She is going to work with probably with the IVUS. Okay, any comments and what is your strategy to discuss and to have the opinion of the panel here?
Maybe. You saw the case, and we've just at the level of diagnostic of right coronary artery, and now we're discussing the guiding catheter for the left main cannulation. And you see the film, you saw the film, and what kind of guiding you recommend to Dr. Chilingirov?
No, this is for the panel.
You're
a part of panel.
We're through the femoral approach because we don't have pulsation of the both radial arteries. The lady had 2 angiograms and sorry.
Anyway, this is osteo lesion, and usually what we do in order to easy our wife and our work is going through the femoral with 7 French because it's a big left main, and doing bifurcation and kissing balloon inflation is sometimes difficult through 6 French, especially with bigger balloons. If he's not completely agreeing with me, but he should agree because there are no pulsation or no radio access.
So this is a good place to say exactly the contrary, you know, because personally, I'm sorry that you have not used the radial. You have good reason, and I will certainly use a 6 French. And the only catheter I will never use, because I consider this is a mistake, is to put an Amplatz, because Amplatz is either deeply inside or completely out. It's difficult to manage when you are exchanging your wires, and the risk is to have a jump of the Amplatz damaging the stenting. So very clearly for me will be 6 French and EBU.
Okay, so we can go for the EBU, but EBU 3.0 or 3.5. It's a relatively small lady. So what are your suggestions, your recommendations?
3.5.
If you allow me, this aorta is a little bit horizontal, and I think that I don't know what is the exactly the angulation between the left main and the aorta, but from femoral, probably it's better to take a left Judkins.
Yeah, I thought somebody would bring that up. Yeah, so especially for left main, you may want to choose a shorter left Judkins, because then it may not, like you said, may not go in all that much. So, you know, JL 3.5 may actually work, but EBU should be okay. But you will know very quickly when it's deep-seated, then you know very quickly that the EBU is not going to work. you have very little control with that,
So-
but maybe Judkins may be better. But I still use.
Okay, we took EBU 3.5.
We'll see
Right.
how it's treated.
Наляво.
Yes, here both options are quite feasible because we don't have a calcified lesion, we don't have a lesion on the L, we don't know, but from angio, we have the circ which is not disease, so it's and what we usually do, especially in my experience, I take a little bit smaller EBU for the left main just to sit it in front of the left main.
Okay.
Put some nitro.
I think I will use
Okay,
for
we'll do
this
some
case.
nitro.
I will use a working projection that will be AP with a lot of cranial or slight aereo, the so-called TB, because here we don't see very well the ostium avelledi. And the second one for
The ostium of
the second one will be probably a spider with a lot of LAO to have the left main inside the trachea, you know.
Test.
The ostium of LED. See very well. I also have
Is
some
this
concerns about the guiding.
osteo LED or just distal left main 010?
What's the difference?
It's
From
about
practical
millimeters
point of
of
view.
the carina, so it's
Because
left main.
I know quite a good number of people who try to put an osteo stent. I know
Without
They're
controlling
very
a
the
good
left
amount
main.
of people
Many-
who will try to put a stent only on the ostium, and that could be a huge mistake.
If you are lucky, sometimes
So you won't go for that.
Yes, sometimes it works, but sometimes it not. And even in cases when it works, in the long term, the result is almost in 70 to 80% terrible. And it is terrible for the patient, not for the operator.
Okay, maybe we can go for wiring.
Yes, just keep your workflow
Erantruth.
according to your.
It will be interesting to put a stent without a wire. I saw it once. Jean Fagede made it on live during PCR because he was so fast that he put the stent and withdrew the wire. I don't know if did you remember this? It was maybe 5 or 6 or 7 years ago.
What do you think about
Yeah.
imaging?
Yes.
Yeah, there's no wire, but there was a small wire at the tip of the bike, which was like this. I used it in the early 80s. Yeah. At that time, a bifurcation was 2 9 French guiding.
Unfortunately, we cannot hear you very well.
Yeah, sorry, because we are not.
If talking
I was
to us,
telling that
we can't
the
hear him.
first bifurcation treatment in the 80s by Gronzig and follows, they used the 2 9 French guiding to do a kind of ping pong, and they put 2 wires and they inflated 2 balloons, one in each on each wire, and of course no stent. So imagine.
Test.
Ah.
Test.
Why not? Are you going to AP with a lot of cranial? Yeah, it's a bit of validation. It will be very quick. So.
Test.
You cannot go more cranial. How much? Cranial 40 already. No, not a good idea. So 45, yeah, suggested 45. Is it good?
Okay,
Or?
I'll try. Test.
No, it's not good. So back a lot RAO with a lot of caudal, or AP with a lot of caudal. Oh.
AP,
Okay.
AP.
Okay.
Because his cranial is good, the caudal will be normally very good. Is bad, the cranial is bad, caudal will be very good.
A little bit wide.
Test. Okay.
Yeah.
Другия водач.
Maybe a bit of RAO, yeah, just to suppress the catheter there. With the radial, we have no catheter there.
And do you recommend imaging at that state?
We cannot hear you well, Eva.
Do you recommend imaging at that state of the procedure? Or to use it only as a optimization?
Can I ask something?
For everything, in case clear.
Yeah?
The femoral access was chosen here because there was no radial artery
Yes.
available?
Yes.
Yes, yes, yes.
Okay. Let me just, I really had a very interesting experience lately, which I was completely unaware of. The IVUS guided puncture of the radials. So, not IVUS, I'm sorry, echo guided, where essentially you puncture almost 5 to 10 centimeters higher than the classical puncture side, echo guided. So a series of, I was really amazed to see people anymore puncture occluded radials, echo guided, 3-4 centimeters or even a little higher.
Okay.
And it works fantastically, I have to tell you that. So essentially you have a direct
Okay,
visualization of the artery, and then you puncture the
may I
radial. I
ask,
don't know if you have done that, or Valery, ever, as an experience. So the occluded radial distally, because the radial is occluding at the site of the puncture. If he's seen reports on recanalization of the radial through the distal radial, because over the access is available around the arch. So they recanalize the radials to do radial procedures by access of the distal radial. But I can tell you, IVUS guided from the radial is really working well.
So George, you bring up a very interesting point. So at the Cleveland Clinic, we use ultrasound guided access for
Should we
both
read that,
arteries and veins very, very commonly. And though we haven't published it, I personally have experience of occluded radials, no pulsatility at all. But on the ultrasound, you can visualize the radial artery with thrombus inside. You can access it, you can get distally, and amazingly, after the procedure is done, you've done some kind of Fogartization of the radial, and the radial pulses back. Because very often it is thrombotic, not fibrotic.
It is the case, yeah, you're right on that. But also, as I'm telling you, even if you don't target this one,
Yeah.
you still can get access to the radials. And actually, the initial part of that was done in accesses for TAVI, where radials were occluded, and the cerebral protection device was an absolute must. And for this kind, if you want to put a sentinel, you need to have a radial approach anyhow, because the device is designed for radial. And then I've seen this placed in such kind of scenario that if you don't have the right radial, you cannot push the device. I was really amazed that you can really puncture the radial a few centimeters higher with echo guidance. And then you can recanalize it, as you said. I mean, you can do things to restore the patency, and it might work sometimes.
So Dobrin is asking for IVUS. Personally,
So
this is not a
suggestions?
provocation. Huh? This is what I will do, seriously. I will stand directly.
Because I just...
Is it a 6 French or 7 French?
Seven.
7 French. I will take probably yeah, 3.5.
It's
Long enough to cover 3.5, let's say 20, 24, 28, something like this.
Yes, but
Directly,
Pre-direct.
coming back to the ostium of the left main, so close to the guiding, I will inflate the 3.5, which is small regarding the left main, immediately do a pot. That's what I will do. No IVUS.
I'm talking about IVUS first because we are on an educational session, and here there is one important point, which if you go directly, but it is good that the audience should be convinced about the sizing of the arteries, because here on the eyeball we see 3.5, maybe 4. This is 7 millimeters. 0.70 multiplied by 7, it's 4.9. And for the pot, I mean, that means that for the pot you should use, let's say, 4.5 or even 5 millimeters. Yeah, but there are a lot of people who are not so convinced and still rely on IVUS, and I think that it will be useful also for the young fellow just to see in reality that this is true.
For me, on the contrary, okay, it's possible to do an IVUS, but imagine this isolated lesion of the proximal LAD is remodeled. So never choose media to media, never. And I'm not sure you need that, because you have the normal diameter, highly visible, just distal, without another bifurcation. So this is the true diameter of the vessel. We can use a caliper and we can measure.
So, Yves, please describe the procedure
You can.
that you will
So
do.
I take
3.5, let me just
3.5,
interrupt.
24. 2 wires.
3.5, 24.
24
Crossover all the
at
way
the
to the
ostium,
ostium.
crossover. Immediately I go to 4.5 for the left main.
Okay.
And after that,
Pot.
I exchange a wire. This is the pot. So I exchange the wires because I don't want to leave, even if the circ is normal, don't want to leave strut in front of the circ. We discussed that already. So I pull my LED wire. I hope it was properly shaped in order to enter the most distal cell, which will be, in my opinion, very easy. So you enter with the LED wire. You remove, of course, if you don't have dissection, then you remove the circ and you put it in distal vessel. A second solution is to bring a third wire that was stitched by my colleague Marie-Claude Maurice, because it gives also a bit of stability of the guiding in the left main, which is, we are very close to the ostium, and we don't want to go inside the left main. So a third wire is also a good option. So penetrate the side branch with a shape coming from LAD, the distal cell, and do the kiss.
So one more question to you. The way that you described it, it doesn't give the 3 diameter stent, because you have a 3.5 stent at the crossover and you have a 4.5 stent at the ostium of the left main and the left main. Where is the third diameter?
The third diameter is the circumflex, which is big. It's 4.0 at least.
Okay, that's what you mean.
So I will finish with a pot not 4.5 but 5.
That's fine. What I'm trying to understand is the following, because what you said for the long term, a very important thing is the appropriate tapering of the stent conforming to the left main and respecting the diameters of the bifurcation, correct?
Absolutely.
So you implant a stent which is 3.5, it sits very well to the distal diameter of the LAD, and then you put it up to 5.0, and then you do the kissing. The ostium of the LAD or the LAD, so you have proximally a stent which is 5.0, and then I will go to the next question about the stent type, and we need your expertise about which stents you would prefer. But you end up directly to the ostium of the LAD from 5.0 to 3.5. Do you do anything for the ostium of the LAD, yes or no? referring to the diameter. Do you dilate with a 4.0, for instance, there?
Of course,
How do
I will, the ostium of the lady, I will kiss. I will kiss with the 3.5, high pressure this time, and with the 4.0 in the circ.
That's
After,
what I'm
after the
telling you.
after the pot, with
That's
the three,
good, that's
I have
good.
two free wires, so 3.5
That's
in the
fine.
LED,
That's what
4.0
I'm
in the
telling
circ.
you. Okay, so that's what my question is. So you will have a 5.0 stand in the left main and 3.5 stand in the ostium of the LED, this way.
Yeah. 3.5 plus 4, 7.5, 2/3.
I don't hear you well.
You see, you know the formula of female. 3.5 in the LED, 4.0 in the circ, that makes 7.5. No, 6, yeah, 7.5. 2/3 of 7.5 is 5. So the third diameter is 5 in the left main. 5 in the left main, 3.5 LED, 4 in the circumference.
Okay, great. Thank you.
What you can do, Ivos, will be interesting.
It's not always easy, I'm telling you. What you see sometimes make your life miserable.
And the most important,
so we have the stand
the most
or-
interesting part comes after placing a stand, because here the angulation between LED and circumflex is shallow. It's around, let's say, 35 to 40 degrees, so we can expect quite a significant carina shift.
Yeah,
Yes.
I agree on that completely, yes.
But which may...
That might necessitate, in this case, that you stand the circ.
No, zero chance to stand the circ. No, no risk.
But you are not going to predilate.
Yeah, you can predilate if you want. I just told you that I probably won't predilate. So maybe Dr. Nair will say me, we don't see calcium. Doesn't mean that they don't. There is no calcium here. So
40% of the calcium is visible on.
yeah, so you know, this is my part of feeling. You know, the provisional strategy was developed by my team, me, and many others in the world. So but I still have a feeling, even if everything was demonstrated. I still have a kind of feeling.
No, but this is-
Sometimes I make a mistake.
This
So-
is, this is
Can I-
something
can I
different.
say-
This-
please, can I say something? Can I interrupt you?
Yeah.
Yeah.
Because I see that we're having a very nice conversation here, but the operator is hearing us. So I want to go back to the fellow. Does he hear me,
Absolutely.
the operator, not the fellow?
He is not already
Yeah.
a fellow, so he's quite
No, that's what I
experienced.
mean. That's the point, because the discussion is, the operator is, does he hear me?
I think he hears you. Yeah. Yes. He
Okay,
said yes.
so my advice, despite of the discussion, is that during a live case, you're the decision maker. So essentially, move on and do whatever you think that is appropriate, and let the commentators discuss. So don't wait for us. Move on and do whatever you think that is appropriate. Of all of these
May I-
things, direct standing, IVUS, and all of this
Jo-
kind of stuff.
George,
the one
may
that
I-
stands on top of the patient is the leader of the case.
Yeah, may I add just George for him, because you know, he's living and working in Bulgaria. I am in France, so probably he has to follow the opinion of his colleagues here.
No, but
No, but that's part of this is part also of all of these meetings and how people are evolving. You always pay to this respect of the people. My comment was that you should respect the people, that they are following your procedure. But at the end of the day, you are the one that you're having the responsibility, and actually the one that you have to face it. So he heard about that, and now it's time that as we continue our talking, that he goes on with the procedure in the way that he wants.
Yeah, go on.
We can interrupt him, or he can interrupt us to give his perspective, or if he wants to ask or something like that. So let's see what the operator will be, and keep on this very, very nice discussion. As always, from me, I always learn.
I would say that the intuition of Aviv is based on extreme experience. So most of us don't have it. So probably
Absolutely.
should follow.
Yes, but I don't like the sentence. Following my old experience, I can tell you no. We have data. We have developed the data for.
So we will proceed with
So that's a balloon as
presentation.
far as I see, correct?
Yeah, yeah.
3.0, 3.5?
I think that he will be helpful for
3.0.
sizing the 3.0
10.
by 15 non-compliant balloon.
Okay.
It's too small.
Yeah,
So,
but
you know, if there is a new approach also. You know this approach, eh?
no, which one?
Yeah. 40 dB.
40?
40 dB and nothing else.
Yeah, the regulating balloon. Yeah,
Regulating
yeah,
balloon.
yeah, yeah, yeah. We were discussing that in bifurcation club this year, and
Yep.
I can tell you there is no consensus. Huh?
Okay.
Absolutely not. All of this is a new field.
Do you think that 3.5 is a little bit?
Yeah, it's a bit small.
Okay, let's not discuss. Put the
Yeah,
IBUS and
because
see
I
what
put-
we are going to see.
But the 3.5 you can
Okay,
move
you
it
insist because I prepared 4.0 stand, but
depending
okay, so we
the
are going to proceed.
depending the stand you
It
choose.
depends
You
on
can
the sizing with the balloon.
you can go up to 5.5 with a 3.5.
Yeah,
Some 3.5.
Eva, I think that 4.0 balloon will lead to enormous carina shifting, and I'm a little bit afraid of acute closure of the circumflex if you put a 4.0 stand here.
I don't think so. But
I know this is
But
if you lose the circumflex, it's
think-
going to be very difficult. But the carina shift might happen.
this is not the end of the story. At the end, if you want to optimize at 4, you can do. No problem.
Okay, operator, what is your decision?
Okay, I'll take 3.5 stent. Okay,
Okay.
okay.
Without
together.
IBUS.
With no divers. It's very nice.
3.5 by 38. So the average will be for optimization, and we'll see.
Yeah, good.
What is very important here is to put it at the ostium.
Eva, did I heard correctly that you said that 38 length?
28.
20.
28.
28. Okay.
28. We discussed between 26, 24.
Eve, can I ask
But
you
it's,
something?
Yeah?
Science.
Do you think that the wire and the circumflex is absolutely necessary?
Oh yes. You know, this is a
Because
principle.
of the angle.
You know, George, you said we are in a fellows course. Yeah, so I know that some people are telling, okay, I can always put a wire for sure, and I would say probably I will be able to do put a wire, you know, in any situation. But this is not a good message.
No, the reason that I'm asking that is not to avoid. I didn't complete.
And
my-
after that, you will have to do a kiss. So you need 2 wires. Why not put at the
I'm not
beginning?
saying no. The reason that I'm asking in this specific situation, I know the principle. When the left main is very short, really short, and you have to trap wires.
Okay.
That's my what I was referring to.
Like
No, a bit back. Yeah, it's good.
back.
You have to cover the upper rim.
And
It is
while
good.
the guiding, you have to.
What do you think? Do you like the position?
No, pull. Here is
Oh,
good.
you have
Here is
to
good. Wait,
move.
yes.
Here is good, and pull the guiding.
Okay.
Because we know now, since the last EBC, maybe the previous one, that stent surprisingly are elongating.
Back.
Okay.
Okay.
Say that again. Stents are.
Stent are elongating when you inflate them.
Okay.
That's curious, huh? That was by a guy from Hungary.
Yes.
Marco, no, I don't remember the name.
Okay.
Nice.
Yeah. What's the pressure?
stents-
12.
The stents, when you are inflating them, they are getting longer.
Yeah, they are getting longer, yeah.
Okay.
Take care during the pullback. Wait for a full deflation of the balloon. If you remove the balloon
Yeah.
not perfectly deflated, then the guiding is jumping inside. So, and yeah. So can we have a result in the previous projection? Just an idea, because this is a course. Normally I'm not doing injection at that time. You see, it's not so small, huh? It's not so small.
So,
We see
maybe
distally,
I
we
will
see.
go for pot with 4.5 balloon. What do
I
you think?
will take I think the final diameter will
4.5.
probably be 5, but with a 4.5 balloon, you can go up to 5. So I would take a 4.5. And in the previous
Okay, that is
previous
C3
position,
patency.
a short one.
Can I come to the previous question? Which was that reference that the stent are elongating? Is it published or it's still...
Yeah, it's published. It's published.
No, they're not
Don't give me a name of Hungarian colleague.
Okay.
Is
okay.
Marco Nocno is from Romania.
Marco Nocno is from Slovenia.
No, this is a name like this from Hungary. He published it.
Okay, that's really interesting.
Ah, you have the same problem as me, George.
Toth, if I remember well.
Yeah, Gabor Toth. Gabor Toth.
Gabor Toth.
Yeah.
Okay.
Okay, can we have the result with by angio? This is not the result, huh? No. So, yeah, this one.
You can approach the left main carefully.
Yeah, you can approach. Take care.
Maybe I will take a balloon and go with the guide and the balloon on it.
For the pot, yeah, to do the test with the... Okay. So a short 4.5. For me, if you want to do a 4.0.
How to test that the pot inflation was enough, or let's say effective? How in practical ways to assess that your pot was really effective?
This balloon, 4.5, semi-compliant, you will go, if you have 10-11 atmospheres, you are 4.5. You are not 4.5 at the first inflation, you are not 4.5 at 3 atmospheres, because the balloons are in fact plastic and, I would say, compliant. Plastic and compliant. So when you inflate the third time, the balloon is bigger than the first time. Okay. So what I do is always several inflation. So the position here is very important. Yeah. Maybe a bit more caudal, if you can.
So this is a 12 millimeter
a
balloon?
A bit more caudal, if you can.
It's
okay.
10. It's 10.
Okay. Yeah, I know this is not good for X-ray, but just a second. Do a test. This is not good. Go. Yeah, a bit more.
10, 12, 14.
Yeah, he's doing. Okay. It's not distal enough, in my opinion.
If you pull your side branch wire after pot and it removes easily, is that pot enough?
Okay.
There is another technique, and
a small test.
Trial.
Test.
The technique called pot puff.
Okay. Yeah, this is a good position. Do it again. Do it again.
Appropriate place. Okay. Test.
Yeah, this is good.
Awesome.
Because distal to the marker, this is conical, so the diameter is smaller. Okay. If it, you can go, yeah, and you can do a third time or a fourth time, just to be sure that the balloon is as is this size, 4.5. Yeah, this one will be good too now.
awesome. Best.
Just a test. No, that's good.
14, 16.
That's good. Okay. So what I would do now is to put a third wire. I think it's more reasonable. You can do a cine?
Yeah, for me too.
If I'm what I was telling about that, I remove my pot balloon after I trying to pull my side branch wire just to see is it moves easily or is it the stent.
When you have a second wire in the circle, I will.
No, I mean that if it still moves easily, I will repeat the pot. This is the point.
Yeah, but if you if you pull the wire, take care the guiding is not
No, I
engaging
mean
the left main.
pull
No?
2-3 millimeters just to see
Да преведе
the movement of the wire.
Well, I don't like this. Sincerely,
Снимай. Okay.
yeah. So you do a shape to go to the distal cell of the circ, but you have to enter with a loop in the LED. Okay.
But I think that we have to
Yes.
post the LED ostium of LED. It's the stent is
Yeah, but it's not time to
There
do
is
it.
waste.
Don't worry. It's not time to do it. If you enter with LED with a loop, there is no risk you go outside.
yeah.
Torker.
Okay, push in the LED. Okay,
Excellent
now
loop.
you pull slowly, and you manage the rotation. So you remove the loop. You manage the rotation, guiding the rotation. Yeah, at the bottom, and you pull very very slowly with some test. Okay, you palpate if you enter the circle. No, you are not in position. Okay, this is good. Pull a bit.
Yes.
Pull a bit. You are not. Yeah,
And
that's good.
Here,
Go.
here. Yeah.
I'm not sure you are in the most distal cell, huh? But so my colleague Thierry Lefebvre will insist to do it again because he won't be convinced. You have a wire inside. Just do a quick cine without injection to see the two wires.
Yes.
Yeah,
This is
there
the
are.
scene without
This
injection.
scene is with.
If the wires are well
you see
separated,
there
this
are
is good.
different-
Yeah, they are
You can
separated.
go
Huh?
also in Spider.
They are.
They are separated. No, this is good. They are separated. You won't see much more than this.
Samus.
Here they
We don't
are.
see clearly the
Okay, what do you
wires.
think? Do you accept the position of the wires?
No, the previous.
No, this is okay. I'll come back to this one. Now, you have to, what I taught to my fellows, you manage your guiding with your left hand. And you manage your wire with your right hand. And you pull the gel wire, pulling also the guiding to be sure that you won't enter the left main.
To secure.
Because if you enter the left main, the wire is outside, you will crush the stent. That stent distortion is known as like this. Was in Excel, was by Akiko. Akiko will be here tomorrow if you want. She found 8% of stent distortion using this technique. So this is related to brutal entry of the guiding in the...
So in fact, the gelled wire wasn't that gelled.
Yeah, was not really severely jet.
That's why was the reason that I was asking.
Okay,
whether
so
you need
can you
to
do a
trap
cine
it.
now? Can
And
you do a
this is
cine?
why I several times repeated that before
Yeah.
removing pot balloon, you should try just
Okay.
Yeah, it's
delicately just to.
So what will you do now?
And the other point,
I will go for
Think-
kiss.
A kiss.
I
So
will post the LED, the LED,
I think that
and
the kiss
Yeah, but you
can
post-
basically do a
you
kiss.
dilate the LED with a kiss.
I can bet that if we do IVUS at the moment, we will see an unopposed struts in the left main.
Yeah, this is under deployed. I agree.
Probably
Okay.
you're right.
I agree.
Date-mi 3 patency.
So take a 3.5 semi-compliant balloon, maybe 4.0 in the LED. Is it 4.5? 7 French? 4.5 in circ?
Maybe I will go with
No,
3.5
4.0.
non-compliant
Yeah, you can go.
for the LED and
Yeah.
3.5
No.
in
This
the
is-
left circle.
This is a mistake.
Have
A
semi-compliant
mistake. When you
or-
inflate in a stented vessel, you use a semi-compliant because semi-compliant is to get a diameter which is too small in LED. If you use a non-compliant, you won't increase the diameter in LED. Okay? So semi-compliant
you
in
think,
LED,
that we are
3.5.
undersized in the LED, right?
And in the circumflex, you can do a 4.0. It can be, it will be stunted. It won't be stunted. So 4.0 can be non-compliant in order to avoid overdilation. Okay? And take a short one for the.
I'm afraid to take 4.0 for the left circ.
Prepare it.
Maybe I will stay on the safe side with 3.5 in the left circ.
In the circ, 3.5? Okay.
Your opinion?
Too small.
For the circ, we prepared
So,
4.15, and for the LED, 3.5.15
3.5
semi-compliant.
for the LED, okay? Oh, wait.
And after that, you will use 4.5 balloon you had already? Or even a 5.0 for the pot will be finished. And of course, will be very interesting to have an IVUS.
Now,
We will do the IVUS to confirm the theory.
Yeah, to see if they're really well opposed,
Exactly.
you know.
So
because
essentially, a procedure
3.5.
was described
Yeah, what
on
then?
the experience and the practice.
Reached.
And then instead of using the IVUS
Reached
sometimes to plan the treatment, let's use the IVUS to see whether it confirms the topping.
yeah, but
And the
you know,
practice.
George, I've never said that I'm absolutely sure that all the patients are treated like this
but I like,
had a full apposition, you know. I try to do the
this
job of
concept,
IVUS. Yeah.
We have the luxury of having you and get your distilled experience and opinion. I like the fact personally that we didn't do the IVUS in advance because we have seen many times the IVUS guided intervention. And we said, okay, let's see what is the reality, which is it's a reality that in many institutions and many labs imaging is not available for many reasons.
Come with the 4.0 now.
14.
Come for the yeah. You can, but don't go close to the bifurcation, huh? You can inflate another time and go to higher pressure because it's too small. Remain inside the state, of course. Don't go to the bifurcation. Don't go to the bifurcation. No.
But
No.
what do you mean?
No.
What's
Yeah.
the purpose of the...
Leave your balloon.
Because we have to.
Leave your balloon there. Come with the 4.0. Because if you are
4.0 for
coming
the,
to the ostium of
Complex
LED,
to make the
you have
kiss
carena shift, and then will be more difficult to re-enter the side branch.
pass
Okay.
with the.
We did a pot to enlarge
Theoretical
the cell.
complex.
If you come back, you will have carena shift.
You mean that if you do that, you might not be able to advance your balloon, not that it will change the final result.
Yeah. No, you
But I
will
think
be.
that he's at the ostium of LED, the left ment is too short, and I think that he's just on the carena.
So about the kissing here, we can you can. How long is your 4.0 balloon?
10.
15.
I think 10.
Yeah, so you can
15.
you can put your
15.
4.0 balloon from the ostium to the ostium of circ. So short.
Yeah.
Just the end of the balloon in the circ, and you pull a bit your LED balloon to have an overlap limited to the polygon of confluence. I mean, 2-3 millimeters both in the same vessel. I don't know if I am clear. Yeah. So I think you can pull a bit the LED balloon,
We can perform stand boost.
and you can also pull the
With the positioning.
You know, the circumflex, you want to open the cell, the struts. You don't want to dilate the circumflex. Huh? Push a bit the LED, not to have oval, not push the LED. Yeah, push the LED. No, not together. No. Forget that. This not together. We want a balloon distal and a balloon proximal. That's good. Just a test to see.
Good sense.
Yeah, a test. This will be good. Just a test. What he said.
Okay.
he's trying. I'm trying.
Yeah,
I'm trying.
yeah. Pull the LED balloon.
Okay.
Pull the LED. Pull the LED. You don't have kiss. Pull. Okay, that's good. Yeah. Okay, you can go.
Okay.
So,
Okay,
what?
You inflate
what is-
the LED
Yeah,
first.
budget
LED
shift.
first. LED first.
If I
So
think
if
that
what
you,
you're
you
saying,
Very nice.
sorry,
what
Joe.
you're saying to us now is that you are
Nice.
essentially during the
And
keys.
now, sir,
So nice.
don't wait now because you don't want a long inflation there.
That's it.
Sir, yeah.
This is a distal optimization technique.
No, this is
If-
not the 4-0, this is a
Смотри,
5-5.
no, 3.
I want to ask you something, Eve.
Yeah.
If you're doing kissing, this is the way that you do the kissing.
Yeah, this is the way that I do the kissing. Yeah.
But this is a kissing which will be followed from pot. This is not a...
No. Just
Could be.
no. I don't agree with you. If I do this way, it is because I don't want to sum the two diameters in the proximal segment. I sum the two diameters in the polygon of confluence. So only 2 millimeters. Look at this result.
And what are the pressures?
Don't remove the balloon. You are not sure you have finished.
Balloon. Снимай. We went with the 3.5 balloon in the LED to 18 atmospheres, and in the left circle to 12 atmospheres.
What was... sorry.
Yeah,
LED.
I think you have to come back
The
a bit.
kissing was
The
at
kissing
level.
was at 10 and 12 atmospheres for both.
Yeah. So I will go back to the circle.
Okay.
What you can do before doing another kissing is to inflate in the circle, only in the circle. I mean, left main to circle, just inflate.
The 4015.
And the balloon in the circumflex is 4.0.
Yeah.
Yeah, non-compliant. Yeah.
You sure?
Compliant was in
I'm
the
sure,
LED.
yeah.
Yes.
Okay, a small test.
Чакай малко.
Actually, as Ravi just said,
Test.
made IVUS and
Yeah, pull. Yeah,
Okay.
that's
Yes.
good. That's
I
good.
like
You
the
can go
position.
up to
2-4-6.
14 atmosphere.
10, 12, 14.
My feeling about bifurcation is
Okay, down.
my knowledge is ruined. Totally. Even how to do kissing bone.
And okay, you have deflated. Normally, when you use only one balloon, you can inflate longer, you know. But okay, this is good. Come back with the LED, and we redo a kissing.
Раздуй това.
And after that, we ask for IVUS to be sure that the result is good.
Okay. Искаш само с този балон стендиш? Okay.
We're going to.
Okay, so the same, huh? That not, no. I don't want to do a double inflation in the left main. I want to dilate.
Sorry, but I cannot hear you.
Yeah, and push your LED balloon. This is not side-by-side inflation. The new kissing is not this one. You know? Okay, so how is the pressure? Good?
Yeah?
Yeah, the patient
So
pressure.
if-
Yeah.
I have a question to you.
Patient is excellent.
So,
If
yeah, yes?
Can you see the stand
So-
image?
when you do this way of kissing,
no.
Sorry,
Nikki,
sorry,
when-
George, I've not.
Just
heard.
change the view from camera. We don't see the stand-bis.
I have a question to you. If
Yes.
when you do this kind of kissing, that you essentially you're targeting a specific space of this dilatation. Essentially, this one might not require pot, as you said, final one. Which one of the balloons are you putting more proximal? The bigger always.
No. Yeah, we can put the. Yeah, of course. No, can be the contrary. Doesn't matter. The problem is not to add the two diameters all along the
Yeah,
left
I
main,
understand.
because this is
I
oval.
understand that you don't want to add the two diameters, but there should be a rule about the size of the balloon, or not?
Добре, раздавай.
Which balloon comes more proximal?
The one who went more proximal was the circumflex, the biggest.
18.
The biggest.
The biggest. That's what I'm saying. The biggest always comes more
Okay,
proximal.
go to 14 atmosphere both, and after that,
14.
okay,
And now
you can
left
deflate.
3.
If you are 14, you deflate. And personally, I will do. I will take the fourth 0 you have, and do a pot. For the pot, this is
5-0.
very important. The pot when you are in double standing, you don't do the pot with the marker at the carena. We do the pot more proximally, in order not to crush the stand.
Снимка. Okay.
That's not bad, huh?
Okay. So I suggest to optimize.
Okay,
Maybe I will go for a
And
final
then
pot
we're
with
going to
5-0
final
balloon.
pot.
What do you think?
yeah, you can use a 5-0 if you want. But don't
Let me
put the
concentrate
marker
myself.
at the carena, huh? Put the marker 2 millimeter proximal to the carena.
Yes, for sure.
Pot balloon, which size? Okay.
5-0.
5-0.
Seems good, huh? Yeah, you have to do the iris. I want to see. Yes. A long time ago, when we did left main intervention in patient refused by surgeon in the 90s, we begin a cold program beginning of 2000. People were sending patients to us. They have dilated the left main with a 3-0. The result was not good.
Хепарина как
Main
же?
is big,
Прям.
always big, even bigger with
Είμαι
iris.
στο σεμινάριο με τους φοιτητές παρακολουθώ εργασίες.
Τι έχεις εκεί μέσα,
Αυτό μου το έφερε μια...
τι είναι γλυκά.
Δεν ξέρω, δεν το άνοιξα.
You put the left main balloon, put it on the LED wire, huh? Of course, a LED wire. Huh?
Yes.
We will try.
Εντάξει, μπορεί.
You twisted the wire?
No,
No.
they're well separate.
I have a rule also for this. On the table, you put the wire with two
Άμα πάντως είναι με...
just as the same position as on the screen. So, no mistake.
Δεν έχει πρόβλημα. Εάν έχει φτάσει σημείο να κάνει
δεν
τώρα χρειαστεί κάτι που...
Okay, show the position. So small test.
Okay,
A bit more distal. A bit more.
Maybe a little.
Okay, test.
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 Okay.
That's good. That's
I
good.
like the position. What do you think? 2-4-6-8-10.
Good position. Go. Go.
Πάει.
Όχι, ένιωθε να κάψει.
14-16.
Go to 10 is enough. Will be yeah. Good. Okay, so it's time to see the result.
Πέταμε την κάλυψη θάλακτου. Α, τι μου την φέρει, αγώνα. Πολύ ωραία να πάμε εδώ πέρα. Μένει μια.
They are protesting, no?
Who's talking in this language?
Καλό. Άντε, γεια. Θα σε στείλω.
George, is it Nefele? Is it Nefele?
No, this is not me. This is from Ioannina.
Yeah.
It's not
It's
necessary.
interesting language and
Nice. Махам.
Yeah. So, yeah, this one. Yeah. Okay, a good cine.
Снимаме.
Wow, what a beautiful case.
Okay, should we go for an IVUS?
I would like to do, but if you have no time or if you consider this is good.
I do have one.
We have 13 minutes, so I think 13 minutes are enough for
I think we
IVUS.
have
Yeah, it's
to,
enough.
because I still
The only reservation that I have here is that I'm not sure whether the stent at the point of the initial stenosis is fully expanded. It's well opposed.
expanded. Yes, I
It
had
might be
some
circular,
concerns.
but I'm not sure whether it's fully expanded for the LAD.
We will see
So-
now with IVUS.
So you will see. We will see with the
Yeah,
IVUS.
that's point one.
You saw
and then
what-
I want
I think this is good because you have the kind of indentation you see normally when you are embedded.
Yeah,
So
yeah,
in
that's
my
okay,
opinion, this is well apposed. Maybe not big enough. That's the question. That's a question. Yeah.
Yeah, no, I said that it's well opposed. It's obvious that you have the indentation. The question is that if it's not big enough, how do you do it from now? You just take a small non-compliant and you dilate the ostium of the LAD, or you have to kiss again?
If you dilate the ostium of the LAD, you have to do a kiss again. So, but we will decide. You know, it's very interesting to decide with the IVOS.
Okay.
The IVOS is coming. I see the prepare.
Yeah. So, but that's exactly what I was saying, that maybe we do IVUS and we say it's finished and then it's done by the book. But if you really need to post-dilate because the ostium of the LAD because you want it bigger, then you really have to repeat the process, correct?
Yes. Yes.
Питая как е Елена. Добре.
I think we use balloons that allow us to have 3 diameters, and they are following the rules. So maybe we have 2 big circumflex and 2 small LEDs. That's possible, but you have a functional bifurcation there.
Interesting.
Okay. Добре.
Thank you.
I know you are not here. Thank you so much.
I will give the microphone to Dobrin because I'm unable to describe the result with IVOS. So
yeah, okay.
Разпознали катетър? Добре.
Може ли да видим камера върху IVOS?
Ще я сложим камерата.
И да мине на голям екран, ако може. Супер. Малко дръпни камерата, че е прекалено голям.
Професионалист.
No. This is the guiding catheter.
Това изкарали сме си лъч от циркумфлекса. Нищо. Някой го е да...
Ники, защо не идете на Silk View?
Сега ще идем на Silk View, само нека да...
Okay.
Имаме.
Great.
Okay.
So this is the image from the left main.
No, this is from the distal LED. You can't see the angel, so те не могат да видят и ангиот?
No, we'll accept the only IVOS is enough. IVOS is enough.
Okay, промиле малко.
Записваме?
What will be the speed of... Okay, good. The speed
is... manual pullback.
These are side bridges.
yes.
These are the... Okay, yes. Maybe Ravi, do you want to comment? Okay. Yeah, it's a very well expanded stent. It will be interesting just at the ostium to see and to measure the minimal lumen area at that point. Here is, yes, this is bifurcation. Okay, very good result in the left main, excellent. Just to see the very ostium, because during the introduction of the catheter, I think that there was one small point with some...
Maybe you can go a little
yes, it's around 12 o'clock. There was maybe 2 or 3 struts, but I think that will be, yeah. I personally would not. You can stop the record.
Искаш напред ли? Okay.
You can stop the record now. Okay. Yes, just pull back from the circumflex and just a measure of minimal lumen area at the LAD ostium. Just before bifurcation, there was some. Yes, just. It is more than if it is more than 5.5, it will be enough.
Я още малко напред. You see? I think that there are some threats on
No.
3 p.m.
No, it's okay.
But it's okay.
Absolutely, it's absolutely.
Айде пак назад малко. A little bit oval.
Yes, measure up. Just a half millimeter in front.
Okay. Малко, да, ти чуваш.
A little bit more. Okay, this point. That's it.
Okay.
Just record and then measure.
Okay.
This is enough, and now.
Давай бек. Давай, излизай и ще мериме после.
Exactly. But it looks fine. And I think this is more than 3 to 5. It's around 7, 8, I think. Just on visual.
Okay.
Yes, they would. Eva, let's measure it. Yeah. Yes. Yes. Even at this point. Okay. Good. Here, Eva, this is okay. Okay.
Almost.
Yes, 8.7 as I predicted it, around 8. More than enough. More than enough. So you made an excellent job. Congratulations. Now, absolutely. Fellow is a relative fellow. Dr. Chilingirov made a really good job. Congratulations.
Thank you.
I think this is. But you see how much different opinions we had, actually. Yeah. Yeah.
I want to remember you that the main reason we are not doing, of course, it's very nice to see the result of a good job, I would like to do that in all patients. So the real problem, if we do IVUS to all the patients we treat for left main, we have to take the money for our pocket. Huh?
Now that was a good demonstration, although done in vice versa, because it's logical when you open the IVUS and you are going to use it to see what you have in advance before the procedure. But it was a very good demonstration on that finally, working blinded without IVUS, we confirmed an excellent result.
Among the population that treated, you may find people with unopposed, not well opposed. This is possible. Of course, this is having. We can even dream of having a balloon with imaging.
Yes, and it is very important to have this self-confidence about what you are doing, that you are doing right, and you are confirming it by the IVUS. Of course,
in a lab where there is no IVUS, so knowing all the clinical scenarios and clinical judgment that you had is very good.
We have IVUS, we have OCT, we have a lot of things, but If we feel that the balloon is not going, so okay, we think we have probably outside the strut. Or,
Right.
You know, so at that time we do an IVUS, of course,
Right.
or an OCT. So.
Yeah.
I mean, the indications for IVUS is to use it. I mean, for intravascular imaging, is to use it. Left main, okay, but when you have something unclear from the angio, that's why that it should be. I mean, there should be a reasonable use of IVUS, especially in such case. It can only confirm what you have done, especially knowing the rule of. I mean, the sizes of the side branches and the main branch and the parent vessel and so on. So you can easily do it without an IVUS. In some cases, for example, when we have many left mains, we have more than 450 left mains. We are following for more than 10 years. In some, it was really interesting. In some, as the last case that we did yesterday, the left main was unexpectedly became significant. The angio was absolutely innocent for a left main. But when you put the IVUS, you see that it is very significant stenosis at the distal part. Across with circular calcium, and we did shockwave and so on, and the result was very good. In some cases, you can put the IVUS, and you can see then the minimum lumen area above 6 millimeters, and you can easily skip the treatment of the left main, which is very important.
An important point concerning my country and probably many others is that we don't have IVUS, this is not reimbursed. We have IVUS, it's not reimbursed.
The
It's not reimbursed because they said us, because we don't have a randomized trial showing that this is better than no IVUS. So they are ongoing, we will have them
very soon.
during 2023 for the first one.
We use IVUS, for example, in left mains in which we have a diseased osteo-circ. And when you have to decide whether we go for provisional strategy or probably we are thinking of double stent technique, two stent techniques. And when you see that the circ is, let's say, the ostium is above 4 square millimeters, what is written in the books, we are quite sure and confident that it is not necessary to go with the second.
Will we see IVUS in circ or not? We have seen, this is big, but...
We have, now it's time for break, and after 15 minutes we are continuing.